Welcome to today's webinar, part two in our two-part webinar series on gastrointestinal health of people with Down syndrome from a primary care perspective. My name is Laura Crone, and I'm the project manager for research and education at the Advocate Medical Group Adult Down Syndrome Center in Park Ridge, Illinois, which is a suburb of Chicago. Next slide. We are a healthcare clinic for adolescents and adults with Down syndrome, ages 12 and older. Since opening in 1992, our healthcare professionals have seen over 6,000 individuals with Down syndrome. In addition to providing patient care, we offer a variety of research and education opportunities, such as this webinar and our online resource library. Next slide. Our online library contains over 500 articles, visuals, videos, and other resources related to health and well-being of individuals with Down syndrome. You can access it free of charge at the link on the slide, and there will also be a link at the end of the slides, and we will provide the link in the slides afterwards. Next slide. Before I introduce Dr. Chicoine, I have a few reminders. This webinar is being recorded, and the link to the recording and the slides from the webinar will be emailed to attendees within 1 week. We will also share it on our social media pages and in our resource library. There will be a Q&A at the end of the presentation. Please feel welcome to submit questions throughout the webinar using the Q&A option in your Zoom toolbar. We will address as many of them as we can. Next slide. Lastly, please note that the information in this presentation is for educational purposes only and does not take the place of working with your own healthcare professionals. Next slide. Our presenter today is Dr. Brian Chicoine. Dr. Chicoine is the co-founder and medical director of the Advocate Medical Group Adult Down Syndrome Center. He is on the faculty of the Family Medicine Residency at Advocate Lutheran General Hospital. He received his medical degree from Loyola University of Chicago Stritch School of Medicine and completed his family medicine residency at Lutheran General Hospital. Dr. Chicoine has provided medical care for adults with intellectual disabilities for over 35 years and has presented and written extensively on caring for adults with Down syndrome. Thank you for being here, and with that, I am going to turn it over to Dr. Chicoine.
Thank you, Laura, and welcome everyone. It's a pleasure to be with you today virtually, really looking forward to this being able to share some information with you and listen to your and try to respond to your questions. Certainly, gastrointestinal issues are common in people with Down syndrome, and there's quite a few of them we're going to talk about today. And so we got a lot of questions ahead of time as well, and we'll try to do the best we can with all of them. So this is part two. We don't typically do part one and two of a topic, but again, because there was so much interest and so much information, we decided to try to break this up a little bit into two presentations. So just as a reminder, in part one, we looked at differences in the GI tract of people with Down syndrome, which can contribute to a number of these conditions we'll talk about today. And then real important, how to optimize gastrointestinal health. So if you did miss the first one, I do encourage you to go back and take a look at that, because that's an important piece of that, which we will not be focusing on today. And then we talked a little bit about some GI symptoms and some GI testing. And there were some questions about GI testing we got, so I'd encourage you to go back and take a look at that first video as well. Today, we're going to really focus on really a trip through the GI tract, if you will. We're going to look at really from the mouth all the way to the anus and everything in between. So, and when start with the upper airway and the mouth, the swallowing dysfunction, and small intestine, celiac disease, and inflammatory bowel disease, and constipation. Focus on the large bowel and several others. So really, there's quite a few conditions we will try to address. Now we're going to kind of go through this pretty quickly, because there is a lot of information, and we do have more information on our website. And we will try to answer some questions as well. But certainly if there's answers you were looking for that you don't find, please feel free to check out our website. And we're constantly updating the information on the website to help you with to learn more about these conditions. One thing I upfront I got to say, we're going to really focus on the common things for people with Down syndrome. While the common things are common, which would make sense, certainly people with Down syndrome can develop other conditions as well that may be less common in people with Down syndrome, but also less common in general. So this doesn't preclude, an individual that had something that's not typical for a person with Down syndrome or not common in general. It doesn't mean a person with Down syndrome can't get that. So as you go through the, hearing what we're talking about, the evaluation, we usually start looking at the common things commonly, as long as those, those symptoms fit something that might, be from a common condition. But again, if either the symptoms don't match those common things, and or we're not finding an answer looking for the common things, or the treatment is not helping, certainly you want to go looking for the additional things as well. So we won't go into all. I mean, there's not time to go through all the different gastrointestinal potential problems. And frankly, as the title indicated, I'm a primary care physician by training. So if we're not finding the common things commonly and not finding an answer to our problems, to the problem we're addressing, certainly we'll be referring to a specialist as well. So that would certainly be something that, as far as learning about this, may also be kind of the way we would think about that as well. So anyway, I really kind of look at this thinking it's sort of a trip through the GI tract, and again, we'll start with the mouth and go all the way through. So really sort of a voyage. And for those of you old enough like I am, can think of the 1966 movie, The Fantastic Voyage, when doctors and scientists were miniaturized and injected into a man to treat a health problem. For those of you not as old as I am, perhaps you might recognize the Magic School Bus episode in which the teacher, the students, and their bus were miniaturized to see inside the body. So we're going to try to kind of give you that picture as we go through the whole GI tract. And we're going to focus on gastrointestinal conditions. And so as far as when we talk about treatment for each of these conditions, in addition to the specific treatment that we'll talk about each condition, I want you to consider the what we talked about in the part one regarding optimizing GI health. So exercise and healthy diet and fluids and trying to limit processed foods and things like that. All of those are part of the treatment, really, for pretty much anything that we're going to talk about today, in addition to the more specific things we'll talk about for those conditions. So again, I won't keep saying, consider the things to optimize GI health, but that's a given as we go through this. That for each of these things, that's something we would encourage. So we'll start with the mouth and the throat, and we may not necessarily think of the teeth as part of the GI system, but certainly they impact the gastrointestinal system significantly. And so people with Down syndrome have more malocclusions, malalignment of their teeth, more missing teeth, and more frequently have gum disease than other people. And all of this can make chewing difficult or chewing problematic. And so, really we're not designed for large pieces of food to end up into our stomach and into our intestines. We're designed to have that food well chewed by the time it gets there. And so, again, if there's malocclusions or missing teeth and people are not able to chew well, then certainly that can cause some challenges, and we'll talk about those. Fortunately, cavities tend to be less common in people with Down syndrome, but again, people with Down syndrome that end up losing their teeth commonly will lose them because of gum disease, which is more common than instead of cavity. So certainly there are dental problems, even if the cavities are less common. So certainly good dental hygiene, regular dental appointments. People will frequently ask about braces. Should people with Down syndrome have braces? So I did find a recent study that showed that braces can be effective for people with Down syndrome, but there are some challenges that oftentimes, because the malocclusions are more exaggerated or more of a problem, braces can be more challenging, and people's ability to tolerate them has to be taken into account, and then the gum disease also has the potential to impact on braces. So braces probably do have more complications in people with Down syndrome than in others, but certainly they can be effective. And we really have not had a large population of adults with Down syndrome that had braces at this point. And so, I think hopefully we'll learn more as more people with Down syndrome are offered braces. We'll see improvement in some of the swallowing issues, the chewing issues, and other things down the road that we just haven't had enough experience with to really understand that at this point. But I'm certainly hopeful that we'll see benefits. Although again, they do come with some additional challenges in people with Down syndrome. And then swallowing is another problem. And I call swallowing the great underappreciated healthcare problem because it just creates so many additional challenges when people can't swallow well. And unfortunately, swallowing dysfunction is more common in people with Down syndrome. And it's differences in anatomy and physiology certainly contribute significantly. But some of the challenges with swallowing are what I call behavioral issues, meaning that they're things that we have control over. And so some of that may be that people eating too fast, not chewing well, certainly are common issues in people with Down syndrome. And then swallowing can also be, we tend to think of swallowing as the mouth and the throat area, but swallowing can also be related to the esophagus or to reflux, heartburn, where acid is coming up out of the stomach. So really important as people are being assessed for swallowing, and we'll talk about the diagnosis here in a second, but thinking not only the upper airway, but also the esophagus and how that may contribute to swallowing issues. And symptoms may be choking or gagging. Some people just don't want to eat because they know that they have a problem and it's bothersome to them that they either feel like they're choking or they're it's a discomfort or it's a fear that they'll choke. And so really looking at those things, looking beyond just the upper airway and making sure we're also thinking about the esophagus. And then, unfortunately, another problem with swallowing dysfunction is aspiration pneumonia, where people will actually food or liquid or even saliva will end up going into the lungs instead of down into the esophagus, into the stomach, and that obviously can be a serious medical problem and can cause people to be admitted to the hospital, et cetera, and is very common in people who ultimately develop Alzheimer's disease, that they also develop problems with swallowing dysfunction and aspiration pneumonias. So as far as making the diagnosis, a speech therapist can be very beneficial. Sometimes the speech therapist or the physician will order a video swallow study, which is where a speech therapist is present, but also a radiologist who provides food and liquids that have barium in them. And so that as the food and liquids pass from the mouth into the esophagus, their X-rays are taken, so get to see if there's spillage of those liquids and food into the airway, into the lungs. And then again, you may want to do an esophagram, which is a similar study, but gives more contrast, and which actually looks at the esophagus, again, because the problems are not limited to the upper airway. And then sometimes an upper endoscopy, an EGD, a scope is done to look and see if there's a problem there, or narrowing or an obstruction or something that is causing this problem, or reflux, as I mentioned. Heartburn can contribute to this as well. So may take us, several tests to ultimately sort out what the problem is. Simple things for treatment: eat slower, chew more thoroughly, and certainly very, very important things. We don't want to just focus on the higher tech medical things, but what are the simpler things we can do at home? Certainly we want to address any underlying conditions that the workup found. Swallowing therapy is something that a speech therapist can do to help people optimize their muscle function and their nerve function so that they can swallow better, as well as learn techniques on some of what I call the behavioral approaches to swallowing, the things that we have more control over, how fast we eat and how big of bites and things like that. For some people, a diet change is appropriate. So, if some people have difficulty, for example, swallowing what's called thin liquids like water or soda or juice. And so sometimes those liquids will be thickened either by what the liquids that are chosen, such as a nectar versus a juice, the nectar being a little thicker, or adding a product that can thicken up the liquids. can be helpful and make the swallowing easier. Some people have trouble swallowing certain foods, and so having the food be softer, making sure the food is mixed with like excuse me, like a gravy or a liquid to make the food less dry so that it's easier to swallow. And sometimes actually going to the length of pureeing the food is necessary just to make swallowing easier. So a lot of different things that can be done with that. Lastly, would be a feeding tube or a peg tube or a tube that's surgically placed into the stomach. Again, we'd really try to save that for the last, and really try all these other things first, if at all possible. We have a number of resources in our library on again, addressing some of what I call those behavioral issues, a healthy eating rate of eating, getting us some information on kind of helping people prepare for swallowing studies. So a number of resources on our website to help with addressing some of these swallowing issues. So as we move down through with our in our journey, we're going now to the esophagus, which is the tube between the mouth and the upper airway and the stomach, down as we continue along. So there's a condition called achalasia, which is a improper contraction of muscles in the esophagus and the sphincter, the muscle between the stomach and the esophagus. So you know that as we eat, that sphincter opens, so food can pass from the esophagus into the stomach and then closes again when functioning normally, so the food doesn't come back up into the esophagus. Well, in some people, and this is more common in people with Down syndrome, this condition called achalasia, where there's improper contraction. There can be spasming, failure to relax. The sphincter may not open correctly, and so this can cause significant problems with swallowing and discomfort. There's genetic cause as far as being caused, genetics, and also there seems to be an autoimmune component to achalasia in at least some people, meaning that the immune system attacks part of the body, in this case, the nerves in the esophagus, and damages those nerves so that they don't give appropriate signals to the esophagus to do its job to pass food and liquids into the stomach. And that does seem to be more, as not all, but autoimmune diseases in general tend to be more common in people with Down syndrome, and this is one of them that seems to be fit that situation. And then sometimes infections can contribute to dysfunction in the esophagus. So again, thinking of you're evaluating someone with swallowing issues, for example, and you're not finding in the upper airway, then you really have to think, could this be a little further down the GI system, in the esophagus could be contributing to the problem. And again, symptoms may be difficulty swallowing, regurgitation, where food comes back up because it's not passing normally in the esophagus. It can cause chest discomfort. Some people develop weight loss because they're not able to eat appropriately. And again, really as far as making a diagnosis, you can do an esophagram, which is, again, a contrast study, where they put some barium in a liquid and have the person swallow it and then do x-rays as it passes. And sometimes an upper endoscopy, looking down with a scope. And there's now something called endoflip, which is an endoscope that's used. They pass the scope down into the esophagus and the stomach, and then they in a sense flip the end of the scope back up into the esophagus, and that helps them be able to measure pressures in the esophagus. And a manometry is another study that where they actually pass a device on a tube into the esophagus, and that device actually measures pressures, and that's another way to get the information is achalasia. And again, this is more common in people with Down syndrome, so certainly something we want to think about. Sometimes they are able to dilate use a balloon to dilate areas that are sort of spasmed, and that can help. Sometimes they can inject Botox into those areas to help them relax. And then there's now something called a surgical myotomy, where they actually, with a scope, they're actually able to cut the muscles that are spasming, and so that they'll relax. And so there's a number of different ways that this can be approached. The Botox injections and the balloon dilatation tends to be more of a stopgap measure. In some situations, that's appropriate. But for a more permanent solution, the surgical myotomy is recommended. And we've had a number of individuals that got the surgical myotomy and have done very well with it and had tremendous benefit. Another condition this is probably more common in people with Down syndrome is gastroesophageal reflux disease or heartburn. And it also can actually, the stomach acid and the stomach context can actually reflux all the way up into the throat. And in that case, it's called laryngeal pharyngeal reflux. So it's more than just going back up into the esophagus. It's actually going all the way up into the airway. And this backward flow of stomach acid in the esophagus and the airway can really cause a lot of symptoms. Who tends to get this? Well, people with Down syndrome in general seem to get this more commonly, but also factors that seem to contribute to this are obesity, having sleep apnea that's untreated tends to cause more trouble with reflux, overeating, consuming caffeine or spicy foods or carbonated beverages can all contribute. And then lying down after eating. Certainly it's recommended to not lie down, for at least an hour or two after eating. And so all those things can help increase gastroesophageal reflux disease, or GERD, it's also called. And the symptoms could be chest discomfort, sore throat, actually get regurgitation of digested food. Some people have abdominal pain, hoarse voice, particularly as the acid, et cetera, gets up into the upper airway and the voice box area. Bronchospasm or asthma-like symptoms if this contents are spilling into the lungs as it comes back. Again, some people can develop difficulty swallowing, and again, some people can have aspiration where this content goes into the lungs and can cause pneumonia. Can cause a chronic cough. Some people just have no other real symptoms, but just will cough on an ongoing basis. And then as it goes up into the mouth, the acid can actually cause loss of enamel on the teeth, and sometimes this is picked up by the dentist that there's a problem, and that the person otherwise wasn't having symptoms or wasn't complaining of. And so that's important to see if the dentist notes that's something we want to take a look at is gastroesophageal reflux disease or GERD contributing to that. Possible complications, there's something called Barrett's esophagitis, which the tissue from this chronic exposure to acid in the esophagus, the tissue could change. And the Barrett's esophagitis is actually a pre-cancer type lesion. It's not cancer itself, but it predisposes people to cancer. And so people with chronic untreated reflux or GERD, they will do scopes and look to see if there's any of this, do some biopsies and look for Barrett's esophagitis and then address that appropriately if that's found. And some individuals actually develop, because of chronic reflux, develop scarring of the esophagus. Any injury can cause a scar, just like on our skin. And the natural history of scars is that they tend to shrink over time. Well, that's wonderful on our skin, but in a hollow organ like the esophagus, if the scar starts to shrink down, that can actually decrease the diameter or decrease the lumen of the opening of this organ of the esophagus. And so that can actually cause obstruction ultimately, or make it difficult to eat solids, but not liquids initially at the beginning, because liquids will pass it more easily. So the scarring, and that can cause a significant problem with reflux, discomfort, swallowing issues, and all sorts of issues with when that happens. And that can be dilated with a scope typically. So gastroesophageal reflux disease typically we diagnose clinically, listening for the symptoms, looking for the signs that there's the problem. Sometimes an upper endoscopy is needed to take a look again and see if there's a problem. And sometimes an upper GI with barium. So we would look at the esophagus and also the stomach, and then see if any of that contrast is going backwards from the stomach under the esophagus. And the treatment is typically avoid overeating, reach or maintain ideal body weight, again, because obesity increases the chance of this happening. Limit caffeine and carbonated drinks. The carbonated drinks tend to, in a sense, the bubbles tend to flow upwards. So out of the stomach up into the esophagus. Caffeine reduces the sphincter, that muscle that's supposed to keep the food in the stomach, reduces the function of that, and so allows the food and liquids to pass more easily backwards. Again, avoid lying down for an hour or more after a meal. Avoid clothing constricts the abdomen. So anything that's compressing on the abdomen can push push stomach contents backwards up into the esophagus. Some people find it elevated at the top of the bed is helpful. Typically, we don't recommend just more pillows because as the person bends at the waist, that actually increases the abdominal pressure and actually can cause more reflux. And so, really elevating the head of the bed would be more beneficial, or a wedge. Some people use a wedge that's helpful. And then treating sleep apnea if the person has sleep apnea, again, because that contributes to reflux. And so other treatments would include antacids, H2, like antacids like Tums, H2 blockers like ranitidine or Zantac, protein pump inhibitors, also called PPIs, and omeprazole, Prilosec, you may have heard of. And metoclopramide occasionally is used, which is a medication that actually helps this esophagus contract and the stomach to contract to push food and liquid through. It does have a number of side effects, and we usually would say that as sort of a last resort of use. So just a case example of common things we would see and how we would approach it. A 23-year-old man with Down syndrome is having difficulty eating, and it's noted he has gagging, choking, and complains of difficulty swallowing. And we would review his eating habits. Is he eating too quickly? Is he not chewing, etc.? Typically, we'd usually order a video swallow to take a look and offer swallowing therapy if there's any problem there. And then also, again, really want to consider that we don't want to miss that there's a problem in the esophagus. We don't want to not go too far, if you will. We want to go all the way, from mouth to stomach to really look and see if there's a problem, there, not just stop at the mouth and the upper airway. So we really want to take a look at all the situations that could contribute to this. So as we move through our journey, we go to the stomach, and ulcers are erosions of tissue that occur in the esophagus, the stomach, and the small intestine. So it's not just limited to the stomach. There's contributing factors include Helicobacter pylori or H. pylori infection, and that really, when that came out, when it first came out a number of years ago, that an infection might be causing ulcers, that was really sort of downplayed, and people said, "Oh, that's not correct." And now it really has been demonstrated that this bacteria can really contribute to ulcers, and we do know that people with Down syndrome are more prone to infections, and so it does make sense that they're probably more prone to this infection as well. Non-steroidal anti-inflammatory medications like ibuprofen or Motrin, and also aspirin can increase the risk of getting an ulcer. And then biophosphonates, which are medications like alendronate that are used for osteoporosis, also can contribute to ulcers. We typically commonly think of that as the esophagus with biophosphonates, but also can be the stomach and also the duodenum, the first part of the small intestine. And the symptoms of abdominal or chest pain, some people will just resist eating. They'll be hesitant to eat because it causes discomfort. Certainly some people will vomit. And then they can bleed, and symptoms associated with blood loss might include dark stools, blood, actually also bright red blood or visible blood in the stool. Some people will vomit blood, and then fatigue or syncope, passing out if the person becomes anemic enough. And again, some of these will bleed slowly, and so they really won't have a lot of symptoms until the person passes out from having such a low blood count. And so all things to think about as ulcers as a possible contributing factor to those symptoms. Again, we want to look at blood tests to make the diagnosis, a blood count, and make sure people are or are not anemic. There are blood tests to look for H. pylori, but more accurate are probably the stool test. They look for H. pylori, signs of H. pylori infection in the stool. So a stool sample or a poop sample is collected and sent to the lab and tested for H. pylori. And then also there are a stool sample will be collected and tested for blood in the stool, even if it's not visible to the eye. And then again, an endoscopy to really look to see what's going on with the potential ulcers or to diagnose them. And then again, the treatment, certainly if it's H. pylori, you want to look, and when they do an endoscopy, they can also biopsy for H. pylori. You want to treat there's multiple treatment regimens with antibiotics for H. pylori. And And then there are other medications, again, like the antacids, the H2 blockers, the proton pump inhibitors, and again, metoclopramide in some situations, as per the discussion on GERD. I should add, some people had asked ahead of time about some obstructions like duodenal stenosis, which is a condition. It's congenital, meaning people are born with it, where the duodenum, which is the first part of the small intestine, can actually be narrow. And some people are born with this, and that is more common in children with Down syndrome than is in other children. And also you can get a duodenal stenosis from an ulcer. So an ulcer can cause inflammation and swelling, and the duodenum, or the lumen of the first part of the small intestine, can be narrowed as well. Typically, duodenal stenosis is a congenital problem, and typically is diagnosed in childhood. But again, in some people, if it's more mild, it may be not diagnosed until later in life. But most commonly, it's diagnosed in children, and they tend to have recurrent problems with vomiting and poor eating and weight loss, and other signs that they're malnourished because of this problem. And again, it is more common in people with Down syndrome than in others. As far as a complication of a gastrointestinal problems, vitamin B12 deficiency, again, does seem to be more common in people with Down syndrome. Vitamin B12 is found in foods such as beef and poultry and fish, eggs and milk. And again, it's more common in people with celiac disease, which is more common in people with Down syndrome. We'll talk about in just a second. Also, vitamin B12 is an interesting how we absorb it. So there's the cells in the stomach called parietal cells make something called intrinsic factor. And intrinsic factor binds to vitamin B12, so that it is then more easily absorbed in the small intestine into the bloodstream. And so if the parietal cells aren't making the intrinsic factor, that can be a reason to have B12 deficiency. Or if the person is not absorbing, has the intrinsic factor, but is not absorbing that intrinsic factor B12 complex into the bloodstream, that can cause B12 deficiency as well. So again, we talk about people with Down syndrome having more autoimmune diseases. You can develop damage to the parietal cells so that they don't make intrinsic factor because of autoimmune disease. And so again, that's potentially more common in people with Down syndrome. And then reasons for people with Down syndrome not to absorb the vitamin B12 intrinsic factor complex would be things like celiac disease, where we know that absorption in general is decreased. And so again, a couple of reasons people with Down syndrome may have more vitamin B12 deficiency. And the symptoms of vitamin B12 deficiency may be a poor appetite. It can cause anemia, fatigue, weakness, numbness or tingling in the hands or feet, difficulty with balance. It can also contribute to depression, cognitive impairment, and dementia. So we commonly will be testing for vitamin B12 in our practice because we think it's more common, but also because it can cause a lot of symptoms that may be somewhat vague and may have a little more difficulty sorting through. So again, blood tests would be the way to make the diagnosis, and prevention and treatment would make sure we're eating foods that have a diet. Our diet has foods that have B12 in them, and for example, people that are strict vegetarians may not get as much B12, and so those folks really have to pay attention to making sure they're really eating some of the foods that do have B12 that would not be excluded from their vegetarian diet, or take appropriate supplements to help with making sure they don't develop B12 deficiency. So it is manageable, but you have to really be aware of it, cognizant of that if you are on a vegetarian diet. And as we move down a little bit further, we'll go to the small intestine. The small intestine is small compared to the large intestine because it's smaller in diameter, but lengthwise it's much larger. We have lots of small intestine, 20 or 24 feet, I think, if I remember correctly. But it's narrow in caliber compared to the large intestine. The small intestine has lots of functions. One of them is absorption of foods, and one of the conditions that can impair that is celiac disease, which we know is more common in people with Down syndrome. Again, it's an autoimmune condition, and kind of recurrent theme that autoimmune conditions are more common in people with Down syndrome. And celiac disease is the sensitivity to gluten that causes an inflammatory response. So the immune system is triggered, and the immune system damage causes inflammation in the lining of the small intestine and causes damage. And in the small intestine, we have things that are called villi, which are like a little fingers that are microscopic fingers, if you will, that extend into the small intestine lumen, so that we can better absorb vitamins, minerals, calories, etc. And so these get damaged, and so it affects the absorption of the nutrients. And again, there's a genetic predisposition, and Down syndrome, having Down syndrome does increase the chance of having this genetic predisposition. Classical symptoms may be diarrhea, bloating, weight loss. But really, if you look at the list of symptoms from celiac, it's very, very lengthy. And it may be things more subtle, such as mood and behavioral change, and many other symptoms. And so, again, we end up drawing a lot of blood testing for celiac, assessing for celiac, because, again, some of the symptoms can be subtle, and we don't want to miss it. So the diagnosis starts with a good history and physical exam. There's blood tests, including an anti-tissue transglutaminase IgA, which is a blood test looking for that immunoglobulin that is causing that inflammation. We also want to make sure we draw a total IgA when we're doing that. So IgA is one of the categories of immunoglobulins that we have, and if you have a deficiency in IgA in general, then you're not going to, when you go to measure the anti-tissue transglutaminase IgA, you're not going to find as much. And it's not because they don't have celiac, it's because they just don't have generated as much IgA that would be considered abnormal. So it's important to do both of those tests when assessing for celiac. And sometimes we end up doing genetic testing as well, looking for the predisposition. If you have a positive genetics test, it doesn't tell you that you have celiac, it just tells you have a predisposition to celiac. The definitive way to make the diagnosis is to do an endoscopy, again, that's past the scope, through the mouth, through the esophagus, through the stomach, and then into the small intestine, where they take a biopsy looking for those changes with the villi and other signs of inflammation. At this point, the main treatment is a gluten-free diet, really eliminating that gluten in the diet, which tends to be in wheat, barley, and rye. And then sometimes it's necessary to take supplements to make sure if you're not absorbing vitamins and minerals normally, you want to make sure you're taking those to make sure that you are getting enough. And typically, we recommend a dietitian consult to help with helping with the diet. And there are certainly a lot more foods now available in the grocery store, as well as a lot more advice on foods you can and cannot eat, and ways to avoid gluten in the diet. It is important to realize that oftentimes, and I think it's getting better, but oftentimes foods that contain gluten, or foods that don't contain gluten, foods that are gluten-free, oftentimes have more sugar and fat in them to make it more palatable. And so that is certainly something to think about when you're looking at gluten-free food, to look at foods that do not necessarily are not as loaded with the sugar and the fat, which has its own potential negative implications for your health. As far as screening and guidelines for adults with Down syndrome, it's recommended an annual assessment for the symptoms and signs. And there isn't a recommendation at this time to do regular blood testing on everybody. But certainly if there are any signs or symptoms, and again, there are many, many, as I mentioned, and so we end up doing a fair amount of testing for celiac with blood work. But as screening everybody every year, it's not recommended at this point. And similarly, the guidelines for children have the same recommendations. Lactose intolerance may be more common. And lactose intolerance is the inability to digest lactose, which is a sugar in milk and dairy. It can coexist with celiac, so it's important to think about that as well. So the people with lactose intolerance have a deficiency in lactase, which is an enzyme in the small intestine that breaks milk. The sugar has two molecules together, and we can't absorb those two molecules together well. So those need to be spliced into two pieces, and then we can absorb that well. And so we have this enzyme lactase in our small intestine, whose job it is to break that sugar into two pieces. And people that don't have as much of that lactase can have difficulties with the lactose lactose intolerance. And the symptoms may be bloating, gas, diarrhea, abdominal discomfort. Again, a good history and physical exam. Sometimes just eliminating lactose in the diet can help make the diagnosis. There is what's called a hydrogen breath test where you breathe and measure hydrogen, which can be abnormal in people with lactose intolerance. And then there's a lactose tolerance test where they actually give you a load of lactose and see if you are appropriately breaking that down or not. Treatment is typically eliminate the lactose in the diet, take lactase supplements, which have the enzyme in them, and you take those, and that helps you break down the lactose in your diet. Probiotics in some people may help, and then lactase treated foods. Milk, for example, is available that's already treated with lactase, and so the lactose is already broken down into the two pieces rather than just the one piece that would be in a non-treated milk. And then another condition in the small and also in the large intestine is inflammatory bowel disease. And that's an inflammation of the small or the large intestine. And again, this tends to be autoimmune. Again, autoimmune diseases are more common in people with Down syndrome. And it can cause diarrhea, abdominal pain, weight loss, and lots of other symptoms. A couple examples are Crohn's disease, which tends to be, not exclusively, but tends to be in the small intestine, and ulcerative colitis, which tends to be in the large intestine. Typically, if I've suspected this is a situation, I'm referring them to a gastroenterologist, typically a biopsy is done to make the diagnosis, but also other testing may be done as well. Typically now it's treated with what are called immunomodulating medications, which impact the immune system to reduce the immune system function on the negative function on the small and large intestine. And then oftentimes the diet changes are also helpful to reduce the symptoms. Now, although the names are very similar, irritable bowel syndrome is different than inflammatory bowel. Where inflammatory bowel, if you look in there, you see inflammation. But irritable bowel, you don't have that inflammation if you look inside, you do a biopsy. So this can affect both the small and large intestines, similar to inflammatory bowel, but it's different. And typically this looks like it's very likely related to the gut-brain interaction. Probably has a lot to do with motility, how the food and waste moves through our system. In the past, these were called functional, meaning we couldn't find a reason for this, but now it's becoming more clear that there is this gut-brain interaction that is harder to measure on many of our tests. And again, it is this interaction between the gut and the nervous system. A lot of symptoms: pain, vomiting, diarrhea, constipation, nausea, bloating, and many others. And this may be more common in people with Down syndrome as well, but very different, it can look very similar, but has a very different cause than inflammatory bowel disease. There are called the Rome 4 criteria. I won't go through all those, but there are very specific guide. Here's what the criteria are to make the diagnosis. And there are multiple subtypes. Some people with constipation, some people with diarrhea. And again, treatment is usually starting with lifestyle. And what I mentioned, all the things we talked about last time, can be very helpful. There are some medications that can help with that. And sometimes there is stress or anxiety can be related to symptoms. And so other therapies such as stress reduction, psychological counseling can also be helpful. And sometimes probiotics help this as well in some people. So a 34-year-old woman with Down syndrome develops worsening diarrhea and some abdominal discomfort over several months. So, when I would see her, I would think of start with a good history and physical exam, consider some labs. And again, in the back of my mind, thinking celiac disease, lactose intolerance, food sensitivities, constipation, inflammatory bowel disease, all the things that tend to be more common in people with Down syndrome. And of course, if we don't find an answer in that, or the treatment is not successful, what else could it be that maybe isn't as common in someone with Down syndrome that could be contributing? So lots of resources on those conditions as well on our website. Gallbladder disease is more common in people with Down syndrome. The gallbladder sits up under the liver, and it secretes enzymes to help with digestion. And there are more common, commonly a common condition with gallbladder disease are gallstones, also called cholelithiasis. And these are these hard pebble-like lumps that form in the gallbladder. And it can cause abdominal pain, vomiting, nausea, diarrhea, indigestion, bloating, intolerance of fatty foods, but it can also cause mood changes. And we've seen several people in our practice who were not able to really complain of the gallbladders, typical gallbladder symptoms of pain. But once we figured out they had they have some behavioral changes, we figured out it was gallbladder. Taking out the gallbladder did actually help their mood. So it is something to think about. So again, blood tests to look for liver dysfunction, which can be a complication. A number of imaging tests, ultrasound, CAT scans can help with the diagnosis. There's something called an ERCP, which is a scope that actually more specifically looks at the duct where the gallbladder can be done. And treatment is typically a low-fat diet. The more definitive treatment is surgery. There are some medications in some people that work for gallstones, but they have a lot of limitations with regards to their effectiveness and their benefit. So surgery, if a real recurrent problem, surgery is ultimately the real treatment. And then liver disease, again, we've talked about the liver there up under the diaphragm and on the right side of the abdomen typically. And one condition that's more common in people with Down syndrome is what has been historically called fatty liver. It's now goes by the name of metabolic dysfunction associated steatotic liver disease. So you can see why we might call it fatty liver. And again, this is from buildup in the fat in the liver and alcohol, obesity, metabolic disorders, some medications, other toxins, the flora in our gut, and obstructive sleep apnea all can contribute to fatty liver. And this is, and some of those conditions obviously are more common in people with Down syndrome. So the symptoms very commonly it's asymptomatic earlier in the course. As it progresses, you can develop symptoms of liver disease, which may be fatigue, jaundice, turning yellow, abdominal pain. Typically, the diagnosis through blood testing and then imaging, looking at, again, the ultrasound or the CAT scan or an MRI of the liver. And then there are some more specific ultrasound tests called elastography, which can help with the diagnosis and how extensive the disease is. Treatment, we want to really work on limiting, helping eating a healthy diet, limiting fats and processed foods and sugars. There are now some medications that can be used to help with fatty liver, and then diabetes seems to make people more at risk for this, and so optimizing treatment of diabetes is also helpful. And then inflammation of the liver can called hepatitis. It can be caused from viruses or other causes. And then again, it can cause a wide variety of previously described gastrointestinal symptoms, jaundice, dark urine, joint pain. Again, diagnosed blood test, imaging sometimes, and occasionally a liver biopsy, depending on the cause. Again, the treatment is very variable depending on the cause, but rest, healthy diet, and foods are all part of the treatment for whatever the cause. Antiviral medications may be indicated to treat it if it's a virus. If there's actually an autoimmune hepatitis, again, that should be more common in people with Down syndrome. There is immune suppressing medications. And then in a much less common situation would be a liver transplant as the disease progresses. The pancreas is an organ in the abdomen that sits on the other side, on the left side, typically from the liver. And although we don't really think of this as a gastrointestinal disease, more of an endocrine disease, but type 1 diabetes is caused a dysfunction in the beta cells in the pancreas, which secrete insulin. Again, it's autoimmune, so again, more common in people with Down syndrome. Earlier symptoms may be fatigue, sense of ill health, and then ultimately, as the person is not able to process sugar, increased urination, increased thirst, and weight loss. There are now some discussions about screening for type 1 diabetes. There is not a universal recommendation for that as well, but that may be coming down the road. Typically, it's diagnosed with blood testing, and then typically treatment is insulin and diet. And then there's also something called exocrine pancreatic insufficiency, and that's where the other enzymes, or the other things that are secreted by the pancreas that go into the small intestine and help us with digestion. Those can also be a decrease in those. And so there may be a decrease in those enzymes. And so that may be poor, again, if you're not digesting your food well, poor digestion, oily, bulky stools, chronic diarrhea, weight loss. So again, we want to diagnose it with typically with stool testing and sometimes blood testing. And treatments would be medications to replace the enzymes. In some cases, a higher fat, higher calorie diet, so that people are getting enough of those foods because they're not absorbing them as well. And often them supplements with vitamins or minerals may be necessary. And then if we're winding our way down through the GI tract, go to constipation. And this is very common in people with Down syndrome, is a change in the frequency, size, consistency, and or the ease of bowel movements. And for people with Down syndrome particularly, the smooth muscle tone, the smooth muscle that lines the large intestine or lines any of the GI tract, and that helps contract and push stool out or move through the system. That tends to be, the muscle tone tends to be reduced in people with Down syndrome. The autonomic nervous system helps cause those smooth muscles to contract. And in people with Down syndrome, there may be, at least in a mouse model for Down syndrome, the mice with Down syndrome, if you will, had fewer nerve cells in the colon. So that may be a contributing factor as well. For some, if we're feeling a little constipated, we use our abdominal muscles to help push the stool out. And we know that people with Down tend to have lower tone in the skeletal muscles as well. So that could be a contributing factor. And then, diet, again, not getting enough fiber, eating a lot of fat, and not drinking enough fluids can all contribute. So all those things are potential contributing causes. Infrequent, hard, or difficult to pass bowel movements. Some people get diarrhea because they're not passing the large amounts of stool, and then liquid stool tends to start to leak around the stool. And then real serious conditions of fecal impaction, where stool just really gets stuck, and that can be in the colon, and that can be a serious problem. Diagnosed with history and physical, x-rays, sometimes colonoscopy, sometimes celiac testing is indicated because in some of our individuals with celiac, they have constipation instead of diarrhea. Drinking more fluids, regularly exercising, eating more fiber, and then certain medications. Ideally, we would prefer not to be on medications long term and do the other treatments if possible. But some people just need to be on that just because there's the other things are just not working correctly. Do not help to resolve the problem. One other thing is that we'll just talk about colon cancer, much less common in people with Down syndrome. And so we're actually, as part of the global healthcare guidelines for adults, we're looking at screening for people with Down syndrome for colon cancer. And we'll be discussing that later this year on what the recommendation should be for people with Down syndrome. And then some people will develop eating refusal. And for us, in our experience, a contributing gastrointestinal cause is very commonly found. So whether it was an ulcer or reflux or celiac disease or whatever, the person seems to have discovered that eating this causes discomfort, and so they'll stop eating. And so really treating that underlying gastrointestinal condition is so important. And then there may be also some psychological components to that contribute to that as well that would need to be addressed. Just going to jump over that. So there are differences in the frequency of gastrointestinal conditions in people with Down syndrome compared to those without. They may present with GI symptoms or non-GI symptoms. So again, although it's a gastrointestinal condition, the presentation may not be, a typical gastrointestinal symptom. Due to limits in communicating symptoms by some people with Down syndrome, or the specifics of their symptoms, they may be contributing, able to relay some concern, but not all the details. It is important to consider a GI condition as a contributing factor when the person has a change in function or behavior. So we commonly see a GI condition contributing. And then effective treatment of GI condition includes optimizing GI health that was addressed in part 1, and then the specific treatments that we addressed, albeit quickly. We have lots of resources. Again, I can talk for hours on this subject because there's such common things, but we have a lot more information in the articles on our website, including a lot of videos and visuals. Additional resources includes our mental wellness book, which addresses some of the complications, the psychological interaction between GI conditions and psychological issues. We have the resources for health professionals through the Down Syndrome Medical Interest Group. And then the conference this summer of both the Down Syndrome Medical Interest Group as well as the NDSC conference in Dallas this summer. We have some references. If you'd like to support our mission, please feel free to donate. And I know I didn't leave as much time for questions as I'd hope, but let's see if we have some questions.
Thank you, Dr. Chicoine. We have a lot of questions, so I'm just going to dive right in. You touched on this with constipation, but we received several questions about long-term use of medications and what some of the concerns are with medications like Prilosec, Nexium, Pepcid, Tums, and Miralax.
Yeah, so first of all, like Prilosec, which would be more used for not for constipation, but for the ulcers and reflux. That would there is some concern about the interaction or contribution of long-term use to dementia, and so really trying to limit those medications if all possible to do all the other treatments to reduce the need for those medications is a consideration, particularly people with Down syndrome we already know are more likely to develop Alzheimer's disease. As far as the chronic use of medications for constipation, again, as I mentioned, we really want to try to limit that if at all possible and do all the other things in diet and exercise and liquids and whatnot. It's really, there are some potential negative complications to using these medications chronically, particularly any of the stimulants. And really just the more you use them, the more you're going to need them. They sort of not dependent like you would a narcotic, but your body becomes dependent on them, their use. So really trying to avoid chronic use if necessary. But really, unfortunately, in our experience, there are some people with Down syndrome who have such challenge with constipation and even end up in the hospital periodically with fecal impaction that you got to try to weigh the good and the bad and best you can.
Thank you. And what about Tums?
Yeah, Tums seem to be benign to use on an ongoing basis. Tums are calcium carbonate, and they may actually, some people take Tums on a chronic basis to help with their osteoporosis, and so there may be an extra benefit to that. As far as I'm aware, long-term use of Tums is not a problem. Although calcium in some people does contribute to constipation, so that ends up being a negative possibility.
Thank you. Just finding my next question here. Do you suggest any particular probiotics?
Yeah, no. And the reason there unfortunately has not, the studies on probiotics are still lagging. So there's a lot of information, and we have an article on probiotics on our website, and so there's more information we need to really study that to have a better sense of probiotics benefit. And the problem with that is there are so many different probiotics that it's hard to do many studies to find the best or find which one's better than the others. And so there really is just not the data to do that at this point. So, but by and large, the one that person will take and if it doesn't seem to be working, trying a different one might be a reasonable thing to do, but there just isn't data to tell us for sure.
Thank you. Is there a way to assess for GERD if the individual is low verbal or doesn't communicate verbally? The individual never complains about having any pain or physical symptoms.
Yeah, that's a tough one, and it's certainly not for any of these conditions. I say that people say that when I was doing general family medicine years ago, I ordered a lot less gastrointestinal testing than I do now because more of my patients now have difficulty complaining of their symptoms, and so we end up having to go looking. If we suspect that might be a situation, the person really can't give us the history, so we do have to go looking. So the short answer would be you may just have to do a little more testing than you might in somebody else to figure that out. But looking like things, is the person having trouble sleeping? Could it be that the person is getting awoken during the night by heartburn? Does the person seem to be having any sort of spitting up after a meal? Does the person feel uncomfortable, particularly after lying down after a meal or eating a large meal. It's really kind of just looking for some of those subtle signs would be. But when push comes to shove, some people just have to do the extra test, perhaps esophagram or an EGD, kind of look and see, is there evidence that this is occurring? It's, the history is so paramount to being able to make the diagnosis, and we don't have a good history. You may just have to go the extra step.
Thank you. We are over time. I'm going to ask a few more questions, and we are continuing to record. So if you're unable to stay, you can watch the recording. What about long-term use of pantoprazole?
Yeah,
Pantoprazole?
that's one of the PPIs like omeprazole that theoretically could cause the dementia. Yeah.
Okay, thank you.
Or contribute to dementia.
Once celiac disease is diagnosed and an individual is started on a gluten-free diet, can damage to the villi be reversed?
Yeah, absolutely. And so once the inflammation, once you're not eating the gluten and triggering the immune system will calm down, and then the body will heal itself. And it may take months, 6 months I've heard, a year even. So it may take a while, but absolutely. Sometimes people will actually rescope and confirm that the inflammation is reduced and the villi have regrown.
Thank you. We received a couple questions about adrenal lethargy. What is known about that in people with Down syndrome?
Yeah, none, especially. I mean, very, very little. Adrenal lethargy, the adrenal gland is an organ that sits, they sit on top of the kidneys on either side. And, the term adrenal lethargy is not generally accepted term in traditional medicine. It does seem to be stress related. The adrenal glands secrete hormones. One of the places is in response to stress, and so there is the sense that some people may not be secreting as much adrenal hormone as they need when they're under stress. So, is my understanding of the condition. And so, again, looking at stress, are there ways to reduce stress that might help with that? Again, healthy eating, I think, and just the information we talked about in the first presentation on good GI health, I think would be an issue. The other thing would be to consider testing for actual adrenal insufficiency, where it's measurable that the adrenal gland is not secreting enough of the hormone. At least in our study, the adrenal insufficiency was more common in people with Down syndrome. So it is something to think about and to consider in those situations where someone would actually be put on a hormone, to replace the hormone that the body is not making. So that would be a consideration.
Thank you. What can be done for frequent burping and or frequent gas?
Yeah, so a common, again, to think about what I call the behavioral approaches to swallowing. When we're eating too fast, which a lot of people with Down syndrome do, and not chewing well, they're often swallowing air as they do that. So that can build up in the stomach and then contribute to burping, and similar to gas, the flatus or passing gas. So that would be one consideration, chewing well. The other thing is, again, I mentioned, our body is not designed to get these large pieces of food into the intestine. So those, in a sense, tend to ferment, if you will, or not literally, but that can contribute to the gas formation. And again, looking at, are there certain foods that are contributing? Does the person have lactose intolerance, which can cause gas formation? Do they have celiac disease and are developing more gas related to poor digestion? So really looking at those things. Looking at the diet, are there certain foods that seem to really contribute to this? Are there foods that reduce the speed that food and waste move through the system, where it tends to sit longer and cause more gas problems? The processed carbs can be a particular problem for some people. So really, those would be the approaches to really looking at to see if there's other things. And if it continues to be a problem, again, there may be some more less common or more complicated conditions that you want to take a look at.
Okay, thank you. What can be done about fecal incontinence?
Yeah, so or stool incontinence or fecal incontinence. So typically that's well, a couple of different things. If you first want to decide if it's a solid stool or a liquid stool, and then I think if it's a solid stool, although it could be liquid stool as well. Is there an actual problem? Again, like in the stomach, we have a sphincter, a muscle that prevents food from passing upwards out of the stomach and the esophagus. Similarly, we have a sphincter, the anus, that helps retain stool until we're ready to have a bowel movement. If that's not functioning, certainly that would need to be addressed, and so that can be assessed for, and then see if there's any potential treatments for that. And again, that would be something I would be referring someone to a specialist, either a gastroenterologist and or a colorectal surgeon to help with that. Sometimes diet changes can be made to help with that. The other thing that probably is more common in people with Down syndrome, at least in our experience, is where although they're having incontinence and even diarrhea, the problem is actually constipation. And so they have a large amount of stool that's just sort of sitting there, and then this liquid stool is leaking around. And there's a condition called encoparesis, which we tend to think of more as in children, where the child is holding the stool and not wanting to go, gets constipated, then gets this leaking stool around it, and then they're trying to hold the stool more. And so really the treatment for that then would be really do a good clean out, try to get all that stool out of there and start anew, if you will. And so really trying to eliminate that large burden of stool that's contributed to the incontinence. But there are a number of other conditions. And again, if we don't find any of those simpler things, then again, I'm typically referring those folks to specialists.
Thank you. Oh, we have so many good questions, but unfortunately we are over our time. I just want to again thank everyone for attending and remind everyone that we did record today's webinar, and I'll be emailing that out to everyone within a few days. Dr. Chicoine, is there anything you wanted to end with?
No, I mean, clearly, could talk for a long time with that. I know a lot of people are having GI troubles. Please for a look at our website and our book and other things. And hopefully you'll be able to find good information there. And then again, if you're not, consider taking a look at those other resources, like the Down syndrome Medical Interest Group and others to get further answers.
Thank you so much. I hope everyone has a great rest of their day.
Yeah, bye. So good to see you with you. Take care.
Thanks. Bye.